So once we make the decision to go to cardiac cath, one of four things can happen. One, we could find that there are no blockages and that this whole thing was just a big mistake. The second thing we could find is the opposite. We could find severe blockages that could require an operation, coronary bypass, perhaps even that very day. The third thing we could find is one or two blockages that we could begin to treat with angioplasty or stenting. And the fourth thing we could find is the beginnings of some blockages that we're going to manage aggressively with medicines for the time being. So those are the four things that we can find. That's the diagnostic cardiac catheterization that's shown here on the left. So two parts to that. There's a right heart cath where we see what the right heart pressures are. And we can measure the cardiac output using thermodilution technique, which we'll talk about when we talk about shock in a couple of weeks. The other part of the procedure, the much more commonly performed part, is the left heart catheterization, where we actually look at the coronary arteries. And then on the right-hand side, you can see the procedures that we can do in the cath lab, PCI or Percutaneous transluminal coronary angioplasty, which we don't do by itself very often anymore. And then stenting, which is by far the most commonly done percutaneous intervention today. So the right heart cath is shown here on the left side of the screen, where we go in through the vein, usually in the groin, and put the catheter into the right heart, and we measure the pressures there, and we check the cardiac output. The left heart cath, then, of course, we have to go through the artery, usually in the groin, sometimes in the wrist, depending on, the patient's risk, etc. And the left heart cath then allows us direct access to the coronary arteries. Here's some more information about the catheterization. Again, the venous approach on the right heart side is much lower risk than the left heart side, but even so, it's a very, very safe procedure to do today. So the catheterization lab looks like this. There's lots of screens, lots of equipment for looking at the arteries and measuring the pressures and all that stuff. There's usually one or two operators there. And when they're in the cath lab, they have to have all that lead on. So the guy over here on the left, you can actually see has this big lead thing on, and that's because of the radiation from the cameras. So the catheterization uses different catheters. The first thing that has to happen is that we have to put the catheter into the vessel. In this case, it's going into the groin, and this is a long sheath that's put in over top of a guide wire using a technique called the Seldinger Technique. And then these catheters are shaped especially so they can go directly into the coronary artery without much effort at all, really. You put the catheter in there and it finds the coronary artery. That's how they're designed. It's pretty cool, actually. So this is the Seldinger technique, and in this we put a catheter or put a needle into the vessel, and then when we get blood back, we put a wire in through the needle. Then we pull out the needle, make a little nick in the skin, and we put in this introducer sheath that has a dilator on it, and then we pull out the wire after we get it in there, and we pull out the dilator as well, and the only thing that remains then is the catheter itself. So this is what the sheaths look like here. There's a venous sheath and an arterial sheath, and those devices stay in so that we can put the catheters in through them. So the catheters actually go in through this little hole here over top of a wire. So the left coronary artery looks like this. And so here you can see the catheter going in. You see the left main coronary artery here. Actually, in this case, I'm mistaken. This is what we call, I don't know what the actual name is, but we call this a double barrel left main, where instead of there being a left main coronary artery, there's actually, it goes directly into the LAD and the circumflex. Usually there's a part of the catheter, or I'm sorry, part of the coronary artery where there's about a length this long of the left main coronary artery, and then the circumflex comes off of there. But in this case, they both come off right at the aorta. And so here we have the circumflex artery that goes around the back of the heart, and here we have the LAD that goes down to the tip of the heart. And along that way, it gives off all these little branches that go down into the septum called the septal perforators. And then you also have these vessels that go off along the other side, and these are called the diagonals. On the circumflex side, the circumflex gives rise to these big vessels here called the obtuse marginals. And here's a little tiny obtuse marginal here. On the right coronary artery, it looks like this. Kind of looks like a big C when it comes off here. And so the right coronary artery gives off the SA nodal artery here, right? And then the AV nodal artery usually comes off around here somewhere. And then further down, we see that the acute marginal branches come off. All right, we don't actually see any in this case. And then the last vessel to come off is the PDA, or the posterior descending coronary artery. Now, one of the cool things that we see when we do catheterization is that if there are chronically occluded blockages here, or vessels that are chronically occluded, the body can often form its own circulation around it. These are called collaterals, and collaterals are one of the magic things that happen that protect patients and allow patients with very severe coronary artery disease to avoid having heart attacks. So these collateral vessels grow around the blockage to supply the distal blood flow. And this is the thing that patients hope to have. We certainly hope that people have collateral vessels, and that would be a good thing, because then they don't end up having MIs. Now, as I said, the most commonly done interventional procedure is the stent in the US anyway. And so the way the stent works is there's a balloon that gets put into the coronary artery, but around the balloon is wrapped this metal stent. And the metal stent goes into the blockage, and then the balloon is inflated, and the stent is put up against the sides of the vessel wall, and it sort of smushes all this cholesterol plaque. And then the balloon is pulled out, and the stent remains. And when the stent remains, then it acts as sort of a scaffolding to hold the vessel open. So we're going to talk more about those stents, but suffice it to say that they are without a doubt the most commonly done of all the interventional procedures today. The other things that we can do, we also have other toys that we can use, like directional atherectomy and ultrasonography that we can look at things with. There's also this laser atherectomy. Sorry, I couldn't remember the name. Laser atherectomy and other kinds of atherectomy devices that we can actually chop away the parts of the plaque. Now, it turns out these sound like they're really cool and they sound like a wonderful thing, but they're not actually as good as you would suspect. And it probably has to do with the fact that when you get rid of this plaque, it's not cholesterol that you're cutting through first. The first thing that you're cutting through is the endothelial layer, right? And so then you leave this bare plaque open in the vessel, and that is atherogenic and thrombogenic as well. So, you know, the days of the laser atherectomy, I think, are largely past now, but they can be useful in certain circumstances. So here's an example of a right coronary artery stent getting put in. So you can see this terrible disease that this patient has in the right coronary artery, and here that looks nice and dark, and then it gets narrower here. You know, it's much wider up here than it is here, and then here there's this grayed out area that doesn't really fill very well. It's probably because there's a clot in there. And then here we have the resumption of the vessel, but then it gets all ratty down here, and then it actually disappears in this portion. What you see here is actually the guide wire that's in here. And then they put some stents in, and at the end, you have a nice open coronary artery that's supplying blood to the distal portion. And so you can see that the flow now has been much better restored in this section. Here's another example of a stent in the LAD. So at this point, there's this little blockage here, and a stent gets put in and resumes the blood flow. But notice that this little vessel that you see here disappears when the stent goes in. So they sacrifice this little tiny vessel that doesn't supply much of the septum for the complete opening of the LAD. And then finally, when people have bypass surgery, sometimes those bypass grafts don't go well, right? And sometimes they have problems. So in this case, we can see that there's a LIMA graft, and this left internal mammary artery graft comes from the chest wall, and it's taken down during bypass surgery, and then it's put here onto the LAD. It's grafted onto the LAD. But here there was a technical problem at surgery, and you can see that there's a narrowing here of the LIMA graft at the touchdown site. So what they did here is they put in, they did some procedure. I don't know if there's a stent in there. I can't tell for sure, but it looks like there probably is a stent that's been put in there to resume blood flow to that LAD segment from the LIMA graft. And then you can see a year later, it's still open and patent. Excuse me. So after the catheterization, we have this problem, right? We have these introducer sheaths or straws in here, and what are we going to do? Well, we got to get them out. And the venous one, as you can imagine, is pretty easy to take out. No problem with that. We'll hold a little pressure on there. It's just like a big IV. But the arterial sheath has some problems associated with it, not the least of which is the fact that there's a lot of pressure behind it, right? So we have these fancy closure devices now that can be put in and used to close the vessel acutely. When that vessel gets closed, there's usually a piece of collagen that's pictured here that gets plugged onto the outside of the vessel. Of course, if it goes inside the vessel, then the whole, then it stops blood flow to the entire artery, which is not good. So this thing is designed to go right on top of the vessel to close the vessel wall. If they don't use an acute closure device, then they use some horrific device like this called the FemStop. This thing gets applied over top of the pelvis, and then there's a strap that goes behind the patient, and then this thing gets pumped up to put pressure. This is upside down. I think you can see that. But when this thing gets pumped up, it puts pressure directly over the artery. This is clear, so you can actually visualize the artery as well, or visualize the skin over the artery, I should say. And it's a very effective tool, but it's incredibly uncomfortable, and patients often have a vagal response while they are wearing this thing. It's not cool. And then we have the radial band for radial artery catheterization. And when that device gets put on, then again, it's clear, so you can see through it. Sorry. It's clear so you can see through it, and we can adjust the amount of pressure that's on it using this little syringe. And then at the end, the vessel is healed and the patient goes home. So what are some of the complications after cath? Well, bleeding is certainly the big one, right? We got to make sure that the patient doesn't bleed. So vigilant care of the cath site is important. Hematoma formation can be a problem. There could also be arrhythmias that happen, and those arrhythmias can happen either because of reperfusion, in the event that they have an angioplasty or something of a chronically occluded vessel, or patients often have AFib after a procedure. The heart doesn't like to be monkeyed around with all the time. Stroke TIA can happen. Worsening MI can happen if we do a stent and we lose the distal vessel or part of the distal vessel. That can result in an MI. There's also pseudoaneurysm. There's abrupt closure of the stent, infection. Because we're using IV contrast for the catheterization, we could have kidney injury, so that's important to know. And then potentially air embolism, but I don't think I've ever seen that. So this is what patients' groins or arms look like after catheterization oftentimes. Here we see the groin site that's very ecchymotic. This is the ecchymosis that resulted from this radial artery site. A lot of blood leaked down into there. This is something important to see. What you see here is ecchymosis that has collected in the retroperitoneum, right? So the vessels, if you go up too high, when you put the catheters in and you go above the femoral ligament, then you poke a hole into the vessel, the blood can leak out into the retroperitoneal space. And in this case, that's exactly what happened. So look for this in your patients, because this is a complication of cath. And by the way, you can lose a ton of blood in the retroperitoneal space and not even know it. So this is an important finding when you're examining your patient. The other thing that can happen is this thing called a pseudoaneurysm. So an aneurysm is where the wall of the vessel pops out. In this case, a pseudoaneurysm is where the vessel wall is fine, but there's a hole through the wall, and now this big blood clot has formed, and inside the blood clot is fresh blood that's coming directly from this hole in the artery. So the way to fix this is to take the patient, or to have the patient get an ultrasound guided closure of the pseudoaneurysm. And the ultrasound tech actually does this, and they just take the ultrasound wand and hold it right over top of the groin, and they see where the neck of the pseudoaneurysm is. They hold pressure right there until they can close it and stop the flow from going into it. Okay. So post-cath care usually includes vital signs every 15 minutes for 4 times 4, then every 30 minutes times 4, and then every hour for a couple hours. Bed rest is important, with the head of the bed no higher than 30 degrees if they go in through the femoral artery. That is if they have a closure device. But if they just come back with their straws in, I'm sorry, I say straws, that's kind of rude. But if they come back with just the catheter still in, then we don't want their head of the bed up at all. Maintaining immobility is important too. We got to make sure that that leg doesn't move. And of course, there's continuous cardiac monitoring.